my thanks for those who have stayed with us for the whole time. It's a slimmer audience than it was yesterday morning. Maybe that's because no one got fed. But not altogether unexpected, these things. And what is said this afternoon is going to be memorialized. It is actually the beginning, if you will, of the integration process, to use one of the terms, of this conference. I think everyone would agree that there's just been a lot of good information presented, both at kind of high conceptual levels and at very granular patient-specific, encounter-specific levels. And one of the challenges that we will have in trying to pull all this together in a report is try to integrate that and make some coherent whole out of it. And my goal, since I'll be working very closely along with my colleagues here, working with the staff on pulling this together and not only memorializing all the data and the concepts, but turning it into something actionable. Now, there is just a little bit of a nuance I should make clear for the record, that at the National Academies, workshops cannot make recommendations. Consensus studies, which of course are evidence-based, much longer-term processes, can make recommendations based on the evidence that's reviewed. This report will likely make a number of observations, and we'll try to memorialize things that were said over the course of the 2 days, and we'll include tables and some figures and other things that will present the information, but it will not use the term recommendation because that's something that the Academies doesn't allow workshops to make. But sometimes they appear kind of like that, but I didn't say that. So the purpose of this session was to just take a few minutes. I'm going to make a few comments, and then I'm going to ask each of the moderators and the planning committee members to just reflect on some of what they heard, what their takeaways might be, and things that we might want to think about as we're starting to try to put this together into a report. And in that vein, I guess I would make 3 kind of high-level observations and then a bunch of other stuff that's just kind of free-floating associations or whatever. I think the first observation I would make is that this is, more than anything else, a change management exercise or a change leadership exercise. It just happens to be that we're focusing on a scheduling system. But as was said on many occasions in different ways, this has all the hallmarks of a large change. You know, the importance of clarifying purpose and goals and values, the critical importance of a communication strategy, the importance of an implementation plan, learning from mistakes, the inevitability of unintended consequences. I am often asked to speak about change leadership, change management, and I have kind of a standard presentation that I give on the 7 fatal flaws of change leadership, kind of patterned after the 7 fatal sins or whatever they were. I'm not a very good Catholic. And they're all the things that we're talking about. You know, you substitute vision for purpose and goals, communication strategy, you know. So that's my first kind of observation, is that one of the lenses that people should be looking at this through is that this is a change management exercise, and all the things we know about change management and what leads to success and what results in failure should be applied to this situation. The instant situation just happens to be the scheduling system. I guess the second observation I would make is just, and some of it goes to the report that we're going to prepare, and that's the challenge of harvesting both the high-level concepts and the granular and the myriad granular details, and trying to turn that into something actionable. Because that's really my understanding of what the desired outcome was, is that we could take all this, gamish it into something that then could be taken to Cerner and have a discussion about, do you have these functionalities, do you have these characteristics? If not, how are they going to evolve? If so, how are they going to be phased in? And, you know, it would be a somewhat of a different type of discussion than the one that vendors often say is, we got it covered, don't worry, we'll take care of you, everything is okay. We'll make sure it works for you. You don't have to worry about it. Because that often doesn't work so well. And I guess the third observation I would make is just and we heard this in so many different ways, the critical importance of keeping the patient at the center of the universe, and designing workflows and business processes from that vantage point. Everything has to flow from the patient's perspective, which is historically not how the healthcare system has been designed and set up. So those were kind of my three big takeaways. There were a lot of other things. We heard about the importance of simplification, about systemization, about standards and standardization while maintaining flexibility, the need for alignment of patient, staff, and clinician needs. It's more about the people and the process than the technology. The need for governance structures and processes, the need to use data and data analysis, data security issues, learning from small-scale pilots and learning from mistakes, and doing that before you try to deploy it system-wide. And those are kind of, those aren't new thoughts or new ideas, certainly for folks who've been around the IT block a few times. We've heard this before, and there are also some longer-term things that are kind of intriguing, like FHIR and symptom-based scheduling and voice-activated healthcare, and all that sounds pretty intriguing, although I think we need to focus on some of the other things in the shorter term. So with that, let me turn it over to Dr. Halumka, and we'll just kind of go down the table here, taking a few minutes to reflect on what you thought.